So first of all, I'm going to go through the pathophysiology of sickle cell disease. Then I'll be talking to you about the prevalence of sickle cell disease worldwide, then focusing in Saudi Arabia. Later on, I will be talking about the complications, liver-related complications that we're going to see in our practice, where you guys have more experience than I do. And then what are the indications of liver transplantation, and what has been the outcome among patients who comes for liver transplantation with the pre-existing sickle cell disease. And then finally, I will be advertising for the clinic that we launched a month ago with the integrated model between the hematologist and the hepatologist to optimize their care. So by all means, I am not a hepatologist, so I'll try to do my best to explain the pathophysiology of sickle cell diseases. So it's basically a gene mutation that happened at the beta 6 globulin chain, where valine will be replaced by the glutamic acid. What that will result, usually it will not cause any problem in the oxygenation phase to the red blood cell. It will be normal. But once the red blood cell becomes deoxygenated or put under stress, cycling will be performed. That will result in stasis, and when stasis is performed, that will increase the risk of thromboembolic phenomena, veno-occlusive disease, acute syndrome, and so on. And that will upregulate the immune system, and the patient may present some multi-organ failure. Per annum, 3 million newborns are born with sickle cell disease. The highest prevalence is in the Middle East and Africa. However, in Saudi Arabia, based on the premarital screen of 1.5 million people, the frequency is not low. You all know that the dominant of sickle cell disease prevalence is in the eastern region as well as in the southwest. It's estimated that 2.7 or 3 individuals per 1,000 have sickle cell disease, not a triad. So based on the math, you would expect that we have more than 50,000 individuals with sickle cell disease. And if you calculate the possibility of those patients who may have a liver disease, which is around 10%, that's a decent number that they will fill up the liver clinic in my practice. Unfortunately, sickle cell disease is considered to be in the 20 causes of death and children younger than the age of 5. It has a significant burden, not only in our country, but in worldwide and mainly in Africa that has limited resources. And the main cause of death is an infection due to splenic infarct that increases the susceptibility of encapsulated organisms such as Strep pneumoniae, Haemophilus influenza, and others. This is a study, a local study from Riyadh, one of the large centers. It's a retrospective study. They looked at the registry. They had 160 patients, and they looked at the burden of the disease in just one hospital. You could appreciate that the annual number of emergency department per visit was 4 per annum. The major reason for visiting the emergency department or even admitting to the hospital is veno-occlusive disease. 20% of those patients actually require to be admitted to the hospital more than 3 times, and the average length of hospital stay is around 6 days. So the question is, can we prevent these from happening and optimize the patient care and quality of life by having an integration model between HEPA and hematologist? There are significant burdens that the patient may face in their career or their lifestyle over the next 30 or 40 years. As unexpected, usually they don't live beyond the age of 40. Silent stroke, cerebellar stroke, is very common among those individuals. As a matter of fact, 90% of the patients with sickle cell disease, they will develop some sort of a silent cerebral stroke. Usually those patients, they do not present with focal neurological deficit, but it will result in implication in their development and in their IQ, and they have a high probability of developing a seizure. And as you can appreciate in the image, in the red line, it represents the hypoperfusion of the cerebellum, and in the purple line, it represents the infarction. So a good proportion of those patients, truly they have a silent cerebral stroke when they present to you, although they don't have a focal neurological deficit. That's something that you need to keep in mind. And it's not only the brain is being impacted by sickle cell disease, but even the kidney. It's estimated that more than 40% of the patients with sickle cell disease, they will have a drop in the GFR by 5 ml per year. And it could affect the glomerular, the proximal, or the distal lobule. A good proportion of those patients patients, they have non-nephrotic range proteinuria as well hematuria. And that is important as well as a transplant hepatologist, because most of the medications that we use in the post-transplant era will result in impairment in the GFR. So you need to have the nephrologist on board early on, especially if you consider transplant evaluation. But my expertise as a transplant hepatologist and liver-related complication, and here I'm going to take you through the next chapter of their end organ damage, which is liver disease. This is an autopsy that was performed in 141 patients with sickle cell disease. It's pretty hard for me to see the slide from here, but from my imagination, I can tell that the prevalence of liver cirrhosis among those patients who had the autopsy, more than 10% actually has an advanced liver cirrhosis. And the majority of those patients, they have iron overload. So the dominant reason that they develop liver cirrhosis is due to iron overload. And you could see there was a drop in the prevalence of liver cirrhosis as well as the incidence of iron overload after the 1992. And I think that has been the reason, because we understood the pathophysiology of sickle disease. We optimized their care with exchange transfusion and blood transfusion, so that maybe have an impact in decreasing the incidence or the new diagnosis of cirrhosis among sickler after 1992. This is a prospective study of 247 patients with sickle cell disease that has been registered at the NIH, and they were followed for 30 months. 10% unfortunately passed away. 4.5% had fibrosis. The ferritin level on most of those patients were elevated, but what's interesting that they found that the ferritin level, if it's more than 1,000 in a follow-up, it has been associated with poor prognosis compared to patient with sickle cell disease who has a ferritin level less than 1,000. And matter of fact, 20 patients who had a ferritin level more than 1,000, when they performed a liver biopsy, they found that the iron concentration on the liver, it was more than 4,000 milligrams. And that is very well established in the literature that is associated with poor prognosis. So you could see that there was a linear correlation between the high ferritin level and fibrosis in addition to mortality. But you need to keep in mind as well, ferritin level is acute phase reacting. It could be elevated for other reasons. Some of those patients actually may have gone from an infection to inflammation to another episode of infection to veno-occlusive disease, and that will result in a high ferritin level. And by all means, we know those patients, they do poorly anyhow, but you need to keep in your mind that at the ferritin level more than 1,000, there is a good probability there is some sort of iron overload in the liver that will result eventually to poor prognosis. A different phenotype or presentation to the hospital with a massive liver veno-occlusive disease. We're not talking about the bone veno-occlusive disease when they present with bone pain, they need rehydration and oxygen and so on, but liver veno-occlusive disease. The liver will be significantly engorged. If you do an image, the liver will be significantly enlarged, and more or less similar to look to a patient who has a cholestatic liver disease. But when you do a liver biopsy, you would appreciate that there is a sinusoidal dilation and hemorrhage in the biopsies. Another presentation that the patient may come with is sickle cell cholangiopathy. This is actually data from the Eastern Province. This is the largest data that has been published in the literature, comes from Saudi Arabia, from the Eastern Province, to describe the cholangiogram features of patients with sickle cell disease. It may manifest in different ways. It may present with secondary sclerosing cholangitis, because what happens when you have these cycling cells affecting the hepatic arteries that supply the bile duct, the patients may present with ischemic cholangiopathy, which is going to be typical, similar to a patient who has a primary sclerosing cholangitis. But in the presence of sickle cell disease, we call it secondary sclerosing cholangitis. But it doesn't mean that the patient may not have a primary sclerosing cholangitis, especially in the setting of inflammatory bowel disease. They may have as well intrahepatic gallstone from hemolysis, even in the absence of stones in the gallbladder. Again, with the same concept of ischemic cholangiopathy, shrinking the bile duct, causing cholestasis will result in stone formation. We touched base a little bit on the precipitating factor of gallstones, so it's due to hemolysis. These stones could be in the intrahepatic bile duct, which results in obstruction, may result in a biogenic liver abscess, as you can appreciate from the image, may present with a secondary sclerosing cholangitis, which is similar to primary sclerosing cholangitis in terms of images. Those patients, they have a higher risk of ischemic cholangiopathy, which is a precipitating factor to secondary sclerosing cholangitis, and you may have an overlap. You may have small ducts, secondary to sclerosing cholangitis, resulting to stasis, stone formation, so the patient may have actually stones as well as ischemic cholangiopathy. This hasn't been published yet, but this is some of the life-threatening liver-related complication that the patient can present to you at the emergency department. Patient may present with sinusoidal obstruction syndrome. Those patients may have an abdominal pain, jaundice, and a large liver. Usually the ALT and AST are elevated, but not significantly, and the total bilirubin is high, more than 20, but less than 250. And there's a good proportion of those patients, actually, they will respond to supportive care. Blood transfusion if they need it, exchange transfusion to drop the hemoglobin S to around the level of 30, and so on. The second phenotype, hepatic sequestration crisis. They present with severe abdominal pain, jaundice, hepatomegaly, but the key factor that the total bilirubin will be higher than what you see in sinusoidal obstruction syndrome, but usually does not exceed 250. The ALT and AST will be elevated higher than what you see in sinusoidal obstruction syndrome, but usually less than 10 times the upper limit of normal. The probability of responding to transfusion and so on is less than sinusoidal obstruction syndrome, but it's worth a try. 1 out of 10 patients may respond to treatment. The worst prognosis is sickle cell intrahepatic cholestasis. They present with cholestasis. Severe elevated total bilirubin, ALT and the AST will be significantly elevated, and as a matter of fact, they may present with multi-organ failure. Those patients usually they do not respond to whatever they do. What do you do? Most likely they're heading to the transplant, and I'm going to be talking about their transplant outcome as well in a second. Now, sometimes it's pretty hard in clinical practice when you see the patient at the emergency department. What's going on? Is it sickle cell hepatopathy? Is it intrahepatic cholestasis of pregnancy? Is it intrahepatic cholestasis secondary to sickle cell, or sinusoidal obstruction syndrome, or so on? So sometimes liver biopsy will be raised, but the problem when you do the liver biopsy in this setting, it is associated with significant complications that may result in bleeding and death. Hence, this is a contraindication to do a liver biopsy in these acute settings. And if you want to proceed with liver biopsy, the best approach will be transvenous liver biopsy. Talking about liver transplantation. So this is from the Solid Registry database from the United States. They have one of the largest volume, 23 patients underwent liver transplantation. 5 patients had simultaneous liver and kidney transplant due to sickle cell disease. As you can appreciate that most of those patients, they are pretty sick. 43% were in the intensive care unit where they matched it with a control, and the control, only 20% were in the intensive care unit. Higher proportion of those patients with sickle cell disease require dialysis compared to a matched control of 5%. And usually in transplantation, we look at 2 outcomes. We look at patient and graft survival, and we use a benchmark of 50% of 5 years. So if you have 100 patients who underwent liver transplantation, if 50 of those live at 5 years, that's considered to be acceptable benchmark in the transplant era. So you can appreciate that 5-year survival as well as graft survival is above 50% among patients who are in need for liver transplantation due to sickle cell disease. This is very acceptable. Now, if you look at the France experience, France has the highest volume of patients with sickle cell. As a matter of fact, they follow 3,000 patients in their practice. Most of those are immigrants, and they have the highest volume of liver transplantation. They divided the indication of liver transplantation either elective or emergency. What do they mean by elective? Elective patients who are being seen in the clinic, they have cholestasis, the MOL score is high, but they are not so sick to be admitted to the hospital. Where the emergency patient who with severe cholestasis or multi-organ failure comes to the hospital, admitted to the ICU, being intubated and requiring a dialysis. If you could appreciate that all the patients are young, the mean age around the age of 37. As expected, 60% of those patients who were deemed to be in the emergent group, they are actually in the ICU, intubated, about 1/3 of those patients, and 10% require renal replacement therapy. Now remember the benchmark we talked about, 5-year survival of 50%. And the urgent group, which is the group who are in the ICU or in the hospital for whatever the reason being admitted, but they are very sick, the 5-year survival is 41%. So it's below the benchmark that we are targeting. However, the elective group, the people who are being followed in the clinic, their most score could be high, but they still be manageable. The 1 and 5-year survival is pretty reasonable. The 5-year survival is 77%. So that raises a couple of inquiries. Number one, who are the patients we can pick and we know that they're going to do well after liver transplantation? These criteria still need to be defined. Number two, are we doing a good job as a community in managing those patients before liver transplantation? And it's not only that, can we prevent them from needing liver transplantation? I think that will be the key question. Because as a transplant hepatologist, my primary goal is to prevent patients from requiring transplant, provide them the quality of life that they need with a reasonable 5 and 10-year survival without liver transplantation. And for those patients who are really in need of transplantation, how can I optimize their care to achieve the 5-year benchmark above 50% and provide them with quality, a good, reasonable quality of life? So there are a lot of queries that needs to be addressed. But liver transplantation will be still in the paradigm as an indication for the sickler who presents with ACLF or acute liver failure or severe cholestasis. But it's not only liver. To achieve curable treatment, bone marrow transplantation. And there is actually specific criteria for the patients who will fulfill that can benefit and be eligible for bone marrow transplantation. And one of those is sickle cell hepatopathy. And you could see the list of other indications that the patient will benefit from bone marrow transplantation. It has a robust 3 and 4-year survival. As a matter of fact, at King Faisal Hospital, before I joined the program, they did a liver transplantation for 2 patients with sickle cell, and 6 months after that, bone marrow transplantation was performed, and they are actually free of disease. But hold on, do we really need to go through the liver transplant pathway, the bone marrow transplant? There is the gene therapy, where it can be given to the patient will be cured. But hold on, there is a specific criteria. Not all the patients will benefit or can get gene therapy due to safety issue. For example, sickle cell hepatopathy is considered to be a contraindication for gene therapy. In addition, the cost. It's a $3.1 million. So there is a financial constraint that not all the patients will be able to get the therapy. And in addition, there is a rigid criteria. Not all the patients can get the therapy, but something can be offered early on for patients with sickle cell disease. So that takes us to the clinic. So since I joined the hospital a year ago, with the excellent and the talent work that both the liver transplant group has, as well as the hematology, can we come with an integrated model that we can offer our patient from the get-go? And the thought is, having such an integrated model in one clinic, you have the hematologist and the hepatologist, you would be able to formulate a plan for that individual. Rather than seeing the hepatologist in day X, and then seeing the hematologist in day Y, and then after that, the patient will be seen again to the hepatology X after having a recommendation from the hematologist, and then the discussion continue by the clinic note between the hematologist and the hepatologist. We'd like to have the discussion on the spot. The patient comes to you, see the hepatologist or the hematologist, follow by the hepatologist, put a concrete plan, then we have another visit a month after that, where all the tests and the blood tests be in order, and then we could discuss what we're going to do next. Is the patient going to go with a transplant? What type of transplant we're talking? Can the patient go for bone marrow transplant alone? Does the patient need just a liver transplant, or does the patient need a sequential transplant, liver followed by bone marrow transplantation? And it's a pilot project. What I mean by pilot project, we we would like to accommodate all the patients with sickle cell disease, but it's going to be very challenging and difficult. We start with the cream of the cream, or the tip of the iceberg. We'll focus first on the patient who will be benefiting from liver transplantation or bone marrow transplant. But hopefully, eventually, we will adapt the France model that we can accommodate sickle cell liver-related complications in general and follow them in the clinic and try to prevent them from needing liver transplantation. It's going to be a good opportunity as well for research, for collaboration, and truly it's a patient-centered care. Please accept my apology that the slide is not shown here properly, but the patient is at the center. You can see we have the hematologist, the hepatologist, we have a social worker, we have infectious disease because they have a higher risk of developing infection because of, as I said, from the encapsulated organism. We have the hematopathologist, and we have pain management integrated because, as we know, all those patients, or a good proportion of those patients, they are higher risk of developing renal-occlusive disease. We have a set protocol in the pre-operative transplant management. If we go into transplantation, they need to be in a target hemoglobin of around 9 to 10. They may benefit from exchange transfusion because we want to drop the hemoglobin as before transplantation to around 30% to decrease the risk of renal-occlusive disease after liver transplantation, because from what has been published in the data, 60% of the patient with sickle cell disease will develop a crisis after liver transplantation. In order to minimize that risk, you need to achieve a hemoglobin S around 30% before liver transplantation. Those patients, they are really highly immunized with alloimmunization, which makes sense because they got a lot of blood transfusions, so we need to check the donor-specific antibody. We may subject them to exchange transfusion before the transplant. A lot of things that we need to address. Did they have silent stroke or not? Because they have a higher risk of seizure, especially if we're going to use cyclosporin or tacrolimus after liver transplantation. They have a risk of non-ischemic cardiomyopathy. They develop pulmonary hypertension, not because of portal hypertension, but because of the stasis and the pulmonary vasculature put them in a higher risk of pulmonary hypertension. So that's need to be addressed. We talked about the renal dysfunction as well, the risk of PE and so on, and then pain management needs to be optimized because number one, they have a high risk of renal-occlusive disease. Number two, you are subject them to stress, which is the surgery. Number three is the surgery itself, which is expected they need to be in a higher dosages of pain management. So that need to be to put all together an integrated plan and pathway for those patients to minimize any hiccup after transplantation. This is an example for a patient that we discussed with the French group. We have Dr. Brahim Abrajhi in the middle here. He's presenting a recipient, and he's presenting as well the haplotypes of 2 donors. And we're talking, okay, which donor will be more suitable for the liver versus which donor will be suitable for the bone marrow transplantation. Because what's interesting is if you do the liver transplantation followed by the bone marrow transplantation from a first-degree relative, they may not be needing immunosuppressive therapy after that. So we do them a favor. We took the liver out, they no more having liver-related complication. We did the bone marrow transplant, we cured them from sickle cell, but eventually they are off immunosuppressive therapy. So in summary, sickle cell disease is a common genetic disorder in our country. It needs a significant attention to optimizing their care, at least from liver perspective, and I think it has been underestimated in terms of the burden because the healthcare is being scattered with those patients with sickle cell disease. As I said, they are more prevalent in the eastern province as well as in the southwest province. And my opinion is establishing a robust integrated hematohepatology program will optimize the patient care. Again, we will be collecting the data, see what happened in a year or two, and collaborating with the French group. I think that will empower us in being at that international stage from academic perspective. This initiative hopefully will result in personalized treatment for each individual patient because not everyone, you can put it actually in the same box because they may present differently, they may have different phenotype of liver-related complication, and hopefully it will increase the awareness from that perspective. And I will be very pleased to answer any question by the end of the session. Thank you.